I have a,
Okay, perfect.
all right. Welcome everybody. This is our University of Minnesota Medical Reserve Corps training on trauma-informed care. My name is Courtney Weddernock. I am the manager of our MRC here at the university. Um, and this is part of our year-long series on disaster behavioral health. I know that we've got both University of Minnesota people, as well as my MRC colleagues from around the country and possibly others. So welcome. We love sharing all of our training and resources with any and all of our partners. This is being recorded and it will be posted to our University of Minnesota MRC website within a couple of days. And if you're interested in any resources that we talk about during the training, we can send those out after the training. We also have some other kind of handouts um, that might be of interest and use to some of you. We are going to wait to do questions at the end of the session. But during the session, if you have any questions, please type them in the Q&A. There's no chat in this webinar, and there's no, the participants don't have the ability to unmute themselves unless we go in and unmute you. So let's try the Q&A function and see how that goes. And if it's easier to just unmute someone to ask a question, we can kind of figure that out and be flexible at the end. All right, let's see. Can I advance the slides? Vaughn, can you go to the next slide, please? So today's presenters are two of my colleagues and friends, Jesse and Vaughn. Jesse is the Director of Operations at Northeast Youth and Family Services, a community mental health center. She's an MRC member here at the university. She has prior teaching experience. I don't know if you're still teaching, Jesse, in the School of Social Work here at the university, and has experience leading trauma-informed care implementation in many different settings. So thank you, Jesse, for lending us your expertise today. And then secondly, we have Vaughn Vu. She is the Associate Director of Operations at Boynton Mental Health Clinic here on campus. And she's also our Behavioral Health Response Team co-lead for our Medical Reserve Corps. So thank you both for being here. I'm super excited and grateful to have you with us today. Next slide. So anytime that we are talking about trauma or emergencies or disasters, there is always that potential for triggering. And so we want to make sure that you're aware of that. We're not going to necessarily talk in detail about any specific situations or scenarios, but we want to make sure that you take care of yourself. So if there's anything that's triggering to you, please, step away, do what you need to do to take care of yourself. We definitely understand that. And if you need any resources or support afterwards, please reach out. All right, so I think I'm going to turn it over to Jesse and Vaughn to take it from here. Like I said, if you have questions that come up throughout the session, please put them in the Q&A and I'll be monitoring that. And then I'll hopefully have some time at the end to facilitate a bit of discussion. So I'm going to mute myself now and I'll let the two of you take over.
Thanks, Courtney.
Thank you.
So I want to go through kind of the agenda and let you know what we'll be kind of covering today, and then we'll look at some of the learning objectives as well. We'll have some moments for self-reflection. This is an opportunity for you to kind of ponder on the questions that we pose and put in your responses as you're able, as you want to, into the Q&A. We'll look at some of the definitions for this kind of field and the work that we do in emergency preparedness, particularly for trauma-informed care, and applying that in the emergency preparedness situations, and then implementing trauma-informed care in a clinical versus a disaster response setting. And then we'll also want to give some time for reflection and planning and discussion. Some of the pieces of learning objectives that we have are looking at understanding common challenges in trauma response teams that any one of us might face responding to a disaster event, and the role of interdisciplinary teams for trauma response, and then trauma-informed care knowledge. Well, hopefully you'll have an understanding of principles of trauma-informed care at the end of this and learn how trauma-informed care can be applied in treatment settings as well as in disaster events. And then learning how to incorporate the trauma-informed care. So kind of starting off just with a reflection question of, what drew you to emergency preparedness work? I recognize, especially with what Courtney had shared, that many of our participants are coming from a wide array of backgrounds and settings. So if you can kind of take a minute and put in our Q&A, what drew you to emergency preparedness, whether that's because of the work that you currently do or the knowledge base that you are able to share and provide. Yeah.
Bon, it does look like, at least for me, there's a chat function now. I don't know if anybody else can see that. So if you all want to use the chat function for kind of the reflection and discussion, and then save the Q&A for questions at the end, that might just help me organize myself a little bit as we go through this today.
I think the chat is showing us disabled for participants, it looks like, or maybe that they can only send messages to us. So maybe that's through the Q&A.
Okay.
So I'm not sure they're able
right.
to use that. But I think, yeah, as John said, reflect a bit for yourself. And if you want to put anything in the Q&A, we're able to see that as we go here live. So if you want to put in any notes about what drew you to this work and to this interest in your career, that'd be great.
Well, Bon and Jesse, what drew you guys to this work?
Great question. I can go first. I can say that I was working as a school-based therapist in 2011 when the North Minneapolis tornado went through my school district I was working in, shutting down the school for a week. And I, with my work kind of on pause, wanted to know how I could help and stay connected with the students that I was working with and their families. And so I contacted the MRC to find out what I could do, and they directed me to the Armory in North Minneapolis. And so I relocated there and became kind of the behavioral health person at that location, just all in the midst of a Monday morning when we were dealing with the aftermath of a tornado. Just out of, I knew that there was a need. I knew that those families that I had been working with in the schools were impacted, and I didn't know how to help and where to find them. And so that kind of urge to be with them through that traumatic situation in their lives was what brought me to this work and made me see the importance of it, for sure.
Yeah, I think that inclination to help and be of help, I think, is really strong. That resonates very much with me. I do urgent and crisis counseling work day to day, and this is an area of specialty that I really enjoy and that I liked to grow my expertise and professional knowledge and work in. So emergency preparedness work was just a natural kind of next step for me, especially with the COVID-19. Jesse, similar to what you said, it's just figuring out how can I be of use, how can I be of help in assisting others during this pandemic and this event. So.
I see notes in the Q&A, making a positive impact in the community, other people's responses. Yeah, I think we want to, especially a traumatic event brings us closer together and wanting to help others and wanting to be together in that. So that's great.
Absolutely. With trauma response teams, there are a variety of events that may initiate disaster response. It can be anything from, natural events, disasters, to human caused. And it can have a wide impact on different communities and significance of impact for different communities. I think with the trauma response teams, there's typically an interdisciplinary approach to the team of responders. We have physicians, nurses, pharmacists, public health, experts, administrative logistics, therapists, counselors like Jesse and I, veterinarians coming in, and even just a lay person. So it's not limited to professional degrees, certainly. And with the interdisciplinary team, there are some, I would say, ethical issues or challenges that come up for practitioners in particular, especially if the disaster is happening in the community that they serve in. So considering the challenges around maintaining appropriate boundaries and discussing this and thinking through this a little bit further, we'll touch on this towards the end of our presentation, but I want to bring it up here because I want to just acknowledge that that often is the case in trauma response teams. And then the last piece is a key aspect of trauma response teams is to reduce the initial distress caused by the traumatic event and foster short and long-term adaptive functioning and coping. This is really the essence of trauma response and at kind of the heart of our presentation and sharing the trauma-informed care information and application with you all. So how would you explain trauma to a friend in 3 to 5 sentences? We're not looking for essays, but it would be nice to hear and see what you all say.
And I think those who are attending here are likely more exposed to and have more knowledge about trauma than most. And so if you can imagine how difficult it is for us to encapsulate trauma in a couple sentences, and we're maybe more well equipped than most, that this is a really difficult and broad topic to put into words and to talk about. And that's one of the challenges as we think about trauma-informed care is how do we even explain trauma to somebody who doesn't know a lot about it or hasn't experienced it themselves, and how do we honor and encapsulate all the different kinds of trauma that people might experience. So reflecting a bit on your own about how you might put that into words. This is the definition, the working definition we're going to be talking through as we talk about trauma-informed care today. SAMHSA, which is the Substance Abuse and Mental Health Services Administration of the government, is sort of the developer of trauma-informed care and worked from this definition of trauma, that trauma is the result of an event, a series of events, or a set of circumstances that's experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So that's a really dense explanation, and it's meant to cover a multitude of things, from a single event of trauma, which might be like a natural disaster or death of a loved one, through chronic trauma, living in unsafe circumstances, witnessing domestic violence, being unhoused or mobile. There's a broad range of traumatic experiences that can affect people. And likely when we're working with someone who's been through trauma, what we want to be aware of is the effect that event has had on them, which is can be different for every single person who was in that natural disaster or the single event that occurred, that we don't necessarily know a lot for that person what the effect was. And we'll talk a little bit about what makes that so complex coming up here in a minute.
Yeah, so we look at the 3 E's of trauma, right? The event, the experience, and the effect of it, all in line with that definition of what trauma is. So the event and the circumstances that cause the trauma itself, we're effectively looking at the sequence. The experience might vary for individual to individual. Feelings of powerlessness may arise, and it can often link with a range of factors, whether it's cultural, social support, or developmental stage. The effect that it bears on individuals can be immediate or delayed onset, and the duration can be short or long term. Similar to kind of what Jesse was saying earlier, this definition that's broadly set is in recognition of the effect of trauma, and that it can impact individuals in a way that might not always be directly connected to the traumatic event. So it isn't always obvious how the impact is.
So to level set and start from the same definition of what trauma-informed care is that we're going to be talking about today, trauma-informed care, again, established by SAMHSA, takes a trauma-informed approach to the delivery of behavioral health services that includes an understanding of trauma and the awareness of the impact it can have across settings, services, and populations. So that's number one, is understanding that trauma exists and impacts people. Viewing trauma through an ecological and cultural lens, and recognizing that context plays a significant role in how individuals perceive and process traumatic events, whether acute or chronic. And trauma-informed care involves vigilance in anticipating and avoiding institutional processes and individual practices that are likely to re-traumatize individuals who already have histories of trauma. So whether or not we're talking about a trauma response team or action, this involves an understanding that most people that we encounter may have experienced trauma. In fact, the statistic is 70% of adults in the United States have experienced a traumatic event in their life, if not chronic trauma. So if we can sort of come at all the work that we're doing in the behavioral health space through that lens of, I'm likely to encounter people who have been through trauma, how do I maintain awareness of that and understanding of that and avoid re-traumatization of someone, or provide the services that I need to provide or work through the institution that I'm working through in a way that's not re-traumatizing to people who have been through that experience. And this is a graphic that I know is going to be difficult to read on your screen, so I'll read some of the important parts, but I think what we wanted to convey is the physiological impact that trauma has on the body. And again, this varies very widely from person to person, but all the different physical symptoms or systems that are impacted when somebody goes through trauma. And this graphic, it's wonderful, and you can access this yourself. It's from the Trauma Recovery Institute, and is more focused on childhood adversity or childhood exposure to trauma, but really emphasizes to me all the different ways our bodies respond in traumatic instances, and especially if exposed to trauma over time and in chronic situations. So I'll start at the bottom with the nervous system and the immune system are very much impacted by trauma. Our sympathetic nervous system, our fight and flight response, is activated in a traumatic situation. And if it can be activated for an extraordinary long period of time, which is dangerous to the rest of our body. But so being in that fight or flight activated system or symptom causes all kinds of ripple effects throughout the body, and the stress response that you're feeling in the body is both heightened in a traumatic instance and then elongated, or maybe has difficulty returning to normal. And our parasympathetic nervous system, the rest and digest sort of counterpoint to that sympathetic nervous system, the one that helps us soothe and calm down, is not able to function likely to bring us back into balance after a traumatic event. And that has effects then, oh, sorry, Vonda, do you want to add something?
No.
Okay. That affects then the immune system. Our resistance to cortisol creates inflammation in the body. It creates reduction in our ability to eliminate toxins in our intestines and kidneys. It creates changes in our hormones. So high cortisol levels create the activity to stress, long-term damage to cells, structures in the body. And then changes our neural pathways and brain architecture. So it creates over time shrinkage in the prefrontal cortex, so the thinking part of the brain, and enlarged and more reactive amygdala, so that emotion center of the brain, being overactive, and the thinking part of our brain underactive and not able to kind of connect logic to what's happening in the situation. It has impacts in our brain waves, the neurotransmitters that are released, and those impacts can be short-term, but can also become long-term and create cellular change, can shorten the telomeres, which prematurely ages us, reduces the reproduction of cells, and can cause disease, and has epigenetic effects, meaning it can turn genes on and off in our adaptive systems, and those effects can last into next generations, can be passed down from generation to generation. So we're learning a lot about the physical impact of trauma. And if you can imagine, all of this is happening beneath the surface. You may not see any of this if you're looking at a person or working with a person who's been through a trauma, um, that their entire body is being affected, and it may not come across to you at all unless you're aware of that and looking for and talking about kind of those responses with them and how to work with that.
Yeah, and I think it's important for all of us to understand and know the physical impacts of trauma, because there can be very tangible or very intense physical reactions to in the immediate experience of trauma. Being able to understand this impact of trauma and then normalizing it for individuals in the moment. Certainly not sharing all of the details of this, but to be able to just normalize and say, yes, that makes complete sense. This event had occurred and this is the effect of it.
Yes. So whether or not someone has long-term effects of trauma likely has to do with the feeling of stress that's created in the body, when we would call that traumatic stress, when it's related to a traumatic event. And some of the symptoms that we might see or people might experience and be able to talk about are a feeling of numbness and detachment. And that's, again, their sort of internal systems being on heightened response and not being able to connect to what's happening in the present moment, and not being able to be physically present. A heightened startle reaction, difficulty concentrating, hyperarousal, sleep disturbances, and physical complaints, all having to do, again, with that sympathetic nervous system overreaction, and heightened sensitivity to even new threats, and even threats that are not immediate, but years down the road, things that can cause that elevated stress response again after a traumatic experience. People can often experience re-experiencing of the trauma, whether that's nightmares, flashbacks, trauma-related hallucinations, intrusive thoughts, memories about the event. And that can, again, be very long-term in the case of like post-traumatic stress disorder, and can be short-term and acute as well. We don't always know how that experience is going to be for someone after a traumatic event. People often experience emotional dysregulation and anxiety, including panic attacks and mood disorders. And again, that connects back to the neurotransmitter changes that are happening in and after a traumatic experience. And then sort of taught fears or fears that might be reinforced because of a traumatic experience that then become generalized to other circumstances or other fears as well. We often see avoidant behaviors, meaning someone's avoiding either reality or the situation that was traumatizing to them. And that might include self-medicating, substance use, sort of a way to deal with emotions without being in them. And cognitive changes regarding beliefs about the future, oneself, and the world. So people's change in worldview can happen after a traumatic experience, and that can have lifelong effects as well. So the 4 R's are one kind of a way to think about trauma-informed care. And this is a graphic that is used in schools, which is another application of trauma-informed care that I think is really great, that a lot of school districts are using trauma-informed care in their disciplinary practices and in sort of understanding the experience of the kids who are showing up in the school district. And the 4 R's are a way to sort of remember the important pieces of trauma-informed care, which are: we want to realize the widespread impact of trauma. That's acknowledging that trauma exists and knowing what happens to people when they have experienced trauma. Checking in regularly, asking questions. In clinical work, it may mean screening for trauma and having awareness of how the kinds of trauma that your particular population have experienced. Recognize how trauma impacts the individual, and that's being able to identify what sorts of things trigger the traumatic response for someone, empowering people to use their learning, their thinking brain, and re-engaging the prefrontal cortex if that has been underutilized, facilitating effective responses and working toward healing, recognizing that healing from trauma is possible, and being able to talk about that in hopeful terms with the person that's been through it. responding in a way that makes people feel heard and understood. So having responses that are acknowledging and aware of the trauma that people have experienced, making people feel seen and heard, providing digestible, consistent information, opening up opportunities for voice and choice, as we'll talk about a little bit later, and then making sure that we're offering services in ways that resist re-traumatization. So recognizing where pain points or potential triggers might be, doing our best to minimize those if at all possible, or to be open about and to make people aware of things that are not possible to control or to stop from happening. Asking people what will support in their healing, and partnering with people to cultivate trauma-informed experiences and environments.
So the 4 R's of trauma, I see them all kind of fitting into the different core actions that are part of psychological first aid. Here are the kind of the 8 core actions, and what you'll see in kind of the preceding slides are outlining what trauma-informed care is, and I will kind of go through and we'll highlight how that shows up in these 8 different core actions, just to be able to draw your attention to the different tasks for these core actions, and allow you to kind of think through how you would want to adapt the various trauma-informed principles or care aspects into these different core actions as you might move through them in responding to a disaster.
Yeah, that's great. Psychological first aid and trauma-informed care have very similar language and goals, I would say, and where psychological first aid emerged from the medical field and trauma-informed care emerged from the mental health and behavioral health fields, their goals and aims are the same. So Yvonne will be pointing that out kind of and making the translations, as some of you may be more aware of one than the other, but they're very similar. So these are the 6 principles of trauma-informed care, and I'll kind of go through them here quickly, but then we're going to spend more time going into each one, and how it may be implemented in some of the services that we're providing. So safety is the number 1 and the first and most important principle of trauma-informed care, is that we want to be able to provide physical and emotional safety for people that we're serving, assess for danger and trauma, respect clients' preferred pronouns and names, being able to share clear guidelines about what's going to happen in the environments that we're helping in, doing all that we can to create a safe feeling environment for someone who has been through trauma, who's maybe lacking that feeling within themselves of safety and needs help and assistance from the outside to feel safe. And we want people to feel safe when they're involved in the care that they're receiving from us. Second is trustworthiness and transparency, and that is our ability to work with people on their goals, being able to be clear about what's being done and what we know and don't know, and being clear and consistent with people. And that establishes a feeling of trustworthiness, which may, again, be lacking for someone who's been through a traumatic experience. They may have a lack of trust, especially in providers, experts, and medical professionals. So that may be a difficult barrier to overcome, and we want to be aware of that and do what we can to establish trustworthiness. We also want to offer, whenever possible, peer support and mutual self-help, that meaning that we're not the expert on what makes you feel better, that you're the expert, and that other people have gone through difficult things and may also have things to offer that are helpful, so that not all the help comes from a person of authority or a professional. The help can come from others who have been through a similar circumstance or similar traumatic event, and also that there's a feeling of I can learn how to help myself as well, and that I'm my best resource in healing from a traumatic experience. Collaboration and mutuality is about using collaborative language, valuing clients and people who've been through trauma as experts in their own needs and wants, and providing or referring them to the specific services that they might need, but a feeling of working with someone rather than working for them or doing something for them, but that we're working together toward a common goal. Empowerment, voice, and choice is about recognizing that people who have been through trauma have strengths and they have really important needs and opinions about what happens to them, and that we need to give them the power to share that We want to hear their voice, and we want to give them choices as to what types of services are offered to them, and make them feel like they have choice in what happens to them, where that's a pretty key piece of a traumatic experience, is that the choice was not given to you. And that is part of what's so stressful and difficult about a traumatic experience. And through all of this, we want to have a cultural, historic, and gender issues lens. So seeing things from the culture and historical perspective of the client, of the person that we're helping, and recognizing sort of the other systems in which they live and operate. And that may make traumatic experiences even more difficult, may make it really difficult to talk about what is needed, may make it difficult to share what safety looks like, but all really important to be aware of and to be open to learning from the person rather than imposing sort of a one-size-fits-all approach.
So here again are where kind of the psychological first aid core actions might line up with the trauma-informed care core principles, or the 6 principles of it. The safety and comfort, very consistent. We're wanting to cultivate that sense of security and safety and reassurance, right? That people are in a safe place now. They're not going to, we're going to strive to not re-traumatize them, and cultivate this ability to settle their bodies. I think that's really essential with the safety and comfort. In the trustworthiness and transparency, that's kind of, I would say that happens throughout all of the different psychological first aid core actions. But really, the stabilization, the contact and engagement, we're working toward clarity of information for individuals to build that trustworthiness and that transparency. As we look to contact and engagement, and then safety and comfort, we're also making the connection to different social supports for individuals to help foster the support system that they may have, whether that's the support network that they may have outside of the event or with other survivors who have gone through the event similarly. And then linking to collaborative services, giving them the voice and the choice to determine the services that they may want to engage with, the resources that they may need, and making sure that we are giving them that information on how to cope as well, and what they want to do in moving forward with coping. So the first kind of 2 core actions, I see that really aligning with the safety and comfort. When we're looking at contacting or initiating contact, it can be either the first responder, the trauma responder is initiating the contact, or it's being initiated by the survivor themselves. And it is always with a compassionate, kind of non-intrusive, helpful manner that we're doing that with. Again, trying to cultivate a sense of comfort and safety. We're using close personal or physical contact. The comfort level to which anyone might be okay with personal or close physical contact needs to be led by the survivor, right? That variance from individual to individual and across cultures and social groups is really important to bear in mind, because in wanting to avoid re-traumatization, we want to respect how others might experience or want to receive safety. And then in enhancing kind of the immediate and ongoing safety of it, that goal is really at the heart of safety and comfort. We want to provide relevant information, but also not overpromise and then underdeliver.
So 2 slides about how we establish safety with some concrete examples. The first being physical safety, how we think about our physical environment and look at that through the lens of trauma-informed care. Some of the things we can think about are, we want to use welcoming language on signs. One of the ways this showed up for me in the first place that I was working, where we were establishing trauma-informed care, was We realized that the first sign someone saw when they walked into our building was no smoking. It was a big no smoking sign. Instead of any kind of welcoming message, we're glad you're here. It's really hard to ask for help, so we welcome you. So that was one of the first things that we changed, was not having sort of a negative or restrictive message be the first thing that somebody sees when they walk into a space. But thinking about that, what's that experience like of walking into a place where you likely don't want to be, especially if you're in a disaster response or a family resource center after a trauma. You're feeling uncomfortable, you're feeling like you're not safe. How do we make sure that we can appeal to their sense of safety? And that may be reflective of just having a welcome sign that tells you clearly where to go, if what you need and where that's offered, or how to ask for help. We want to think about how areas are well lit, making sure that we're not, again, doing anything that might re-traumatize someone who's been through a traumatic experience. We don't want darkness. We don't want a lot of corners or places where it doesn't feel safe to an individual. We want to monitor who's coming in and out of spaces and make it clear that that's being done. Another element of being through a traumatic experience is not feeling safe around strangers or people who are in a busy and overstimulating experience and environment. So if there's anything that we can do to assure people that there is safety, that there's some security measures in place in the space, that helps them feel safe as well. If we can keep noise levels low or have ways of dealing with noisy outbursts or noises in the environment, and make it clear what we're doing to minimize that for people, that helps as well. And making sure things are really clearly labeled. We don't want people to have to guess what to do or where to go when they're feeling traumatized. Again, their prefrontal cortex is not active in the ways that it normally would be. So they're not be able to think clearly, well, I should go to find a help desk or find a person with a badge. We want to make it really clear where things are, where the exits are, where the bathrooms are, things like that, that we can really take away some of the question and the uncertainty of the experience for people.
Yeah, and as part of that physical environment, thinking ahead to, what are the different cultural needs or physical needs that individuals have, whether that is to have different size chairs, that, whether it is to have kind of quiet, safe spaces that are out and away from, the larger area. So that, and then having different sensory options for individuals, taking into consideration what their sensory needs might be, because everyone's response to trauma can be very different. And the degree to which their senses might be overloaded, especially in the immediate after effect of a traumatic event, would really help if we took those things into consideration.
Right, thank you. And then thinking about safety at maybe a deeper level, how do we provide a feeling of social and emotional safety? So beyond the physical environment, how do we think about welcoming visitors, ensuring that they feel respected and supported in as much as we can? So thinking about how people are greeting people, what the feeling is of that sort of environment that they're being greeted into, what's said to them about what they're going to experience. Are they greeted in a way that makes them feel respected and supported, rather than like a burden or like somebody who's not welcome in the space, and that their needs are not important? We want to make clear how conflict is going to be managed if that happens in a space that we're working with people in, that we have some guidelines, some regulations, and some limits. Limits are actually helpful for a person who's been through traumatic experience, that they want to know what the rules are and that there's consistency and a clear plan for things, makes them feel less like something scary might happen, or that there's not a plan to deal with something serious that might happen. So making clear, having a plan for conflict if that occurs, and making that plan clear to people if we can. We want to be consistent, schedules, procedures, keep those consistent whenever possible, and make those clear and outlined for people so that they know what to expect. Again, sort of having a feeling of that I know what's coming can be really helpful for someone with an overactive sympathetic nervous system who's in fear response. Giving sufficient notice when changes need to happen. So being really clear with people, I will let you know if that changes, but here's what the plan is, can be really helpful. Maintaining open, respectful communication. And in all of this, being aware of how culture can affect how we perceive trauma, how we perceive safety, and our needs around privacy that differs in different cultures, and that we want to be able to respond to different needs in different ways.
Yeah, and just to reiterate that again, knowing that there may be different functional needs, just thinking about how we might arrange the response space, the family assistance center, how we might logistically think through the flow of traffic or the flow of how individuals are moving through that space would be contributing to that sense of safety. Knowing too kind of the communication needs that different individuals within that community might have, and certainly the cultural or language needs that might be present. And then again, the sensory considerations. So here's kind of a reflective moment. What are some of the examples of helpful statements that you might think of in welcoming individuals into a space, whether that's the Family Assistance Center or the Witness of, Support Center, that would help anchor and give that sense of safety and comfort?
Yeah, and I think if you reflect back, you can think about some things that maybe when you were in a difficult situation or going into a medical or an unfamiliar setting, some of the unhelpful things that were said to you. I can think of times going into a medical setting with my children where if the greeting was, we don't do that here, or you're in the wrong place, or yeah, you're not in the right spot, you got to go down the hall. Like those kinds of welcomes are not welcomes, and make me feel like, oh, I'm doing something wrong. I'm not asking for help in the right way. This is not a place to get my needs met, rather than if I'm welcomed with oh, I'm so sorry, you got mixed up directions. Let me point you clearly to where you need to go, or something that makes it clear that I'm in the right place, that assistance is there and is going to be provided, and that there's some clarity. Somebody wrote in the Q&A that you're in a safe space, you're in good hands, as a helpful way to greet someone, to make someone feel welcome and respected and supported.
Yeah. I love that point, Jessie, and that example, because I think in line with the, contact and engagement core action, we want to be able to keep a presentation of like no wrong door. So when we're initiating, contact, even if we're not the right person to address the need or concern that's coming up for that individual, just to acknowledge and say, you know what, I don't know the answer to that, but I really want to help you get this sorted out. Let's find the right person, and just walking with them and going with them to seek out the help that they might need, even if you're not the right person for it.
Yeah.
Okay, so what might it look like to use compassionate language to promote that sense of safety? One, statement that I have in mind that comes to my mind that's not helpful would be, that was crazy what happened to you. That doesn't, it just goes to kind of highlight the experience, and it doesn't help direct the individual to a sense of safety. It might feel like we're acknowledging and validating for the individual, and in that moment when their prefrontal cortex is not happening, ways to kind of reframe that and just allow them to say, or at least allow them to hear, like, you're in a safe place, you're in the right place, and we're here to help, right? We don't need to highlight all the things, all the scary pieces that had happened already. We just want to reassure and provide that sense of anchoring. Yeah.
That's great. That's a great example. I think too about, in many settings, we might be offering help where there is paperwork that has to be done, and that's not, it's not possible to skip that as part of trauma-informed care, but how can we talk about that with people in a way that's compassionate and that promotes a feeling of safety, to say, we have some documents we've got to get through. I want to do that in the time that feels best to you. So if that means first we take a break and get a snack, or I can tell you how long it's going to take, and we can kind of go through that slowly together. Can we start it now and finish it up later? So offering some choice, offering some options for people, and recognizing some of the parts of the experience aren't going to be comfortable, but how can we talk about them in a way that makes them feel supported through that? It's a great way to think about promoting safety.
Yeah. Because there can be an array of different responses to trauma, there may be situations where you're observing individuals who are having a strong emotional, reaction. Maybe they're pacing, or maybe they're, getting really activated in that moment. Something that would not be helpful to say would be a statement like, please calm down. That really diminishes the impact and the experience that the individual is having. It does not promote a sense of safety, and it's certainly not compassionate. So coming alongside the individual and just to acknowledge and say, everyone experiences trauma differently, and it makes complete sense that you're experiencing the intensity that you are. How can we, help you in this instance? Or can I walk with you? Or, can I bring you to a place that might feel more comforting and allow you to have the experience that you are? Because then we're giving them some choice in that, but also respecting the fact that others, in that same space, who are survivors might have other needs and could be similarly activated.
This bridges really nicely to trustworthiness and transparency, which again is sort of how do we establish, even though the person coming to us may not easily trust people or have a feeling of trust in professionals or in helpers because of things that they've gone through in the past. How do we at least do our best to establish trustworthiness? And often that's through transparency, being open about here's what my role is, being prepared to explain your role clearly and simply and in understandable terms. Share what is known and not known. So, if you don't know what the next step is, that's okay to say, and to say, we'll find out together, or here's the best person that we're going to talk to find that out, or here's when I'll be able to share that information with you. Anything that we can share that's open and honest with the person works to establish some trustworthiness. So as much as we can use clear, plain language, not jargon, and thinking about that ahead of time. Where are the places where we might be drawn to use jargon because we're in the mental health field or in the medical field, and what seems clear to us may not be clear to somebody who's especially gone through something traumatic and is not kind of in their thinking brain. So how can we not use acronyms? How can we be really clear and plain about what we mean? How can we provide really tangible next steps, offer a plan or offer some choice in some plan? And then check for clarity to see if there was understanding there, or if not, if there's someone else, if we need someone else to help with making things clear for people.
I think the nice piece about trauma response teams and often doubling up, so going in pairs of 2 to respond, is that we may not always be aware of the impact that we have given the role or our, the way that we show up into situations. Being a mental health care provider, I may not fully understand all the assumptions that someone might make as they know that I'm a mental health provider. So allowing them to, and meeting them just where they're at, and hearing and taking their lead on what they need right now. If they're not comfortable talking with me as a mental health care provider, maybe they're comfortable talking with my colleague who is a logistics person and presenting in a different way, right? Like allowing choice in where and who people are initiating contact with. I think this graphic from Mintier it just really beautifully looks at how we foster trust, how we can communicate in a way that fosters trust. So flowing from this space of integrity, having consistent messaging, being clear and concise in what we're sharing or communicating, setting that intentionality of putting the survivor's needs first and foremost, and helping to cultivate that sense of safety and comfort. And then, of course, being transparent about the information that we know and the information that we do not know, and not over-promising out of this sense of wanting to help, because we want to do all the things for individuals as we assist them. Following these different elements in our communication can build that sense of trust and reliability for the survivor. So the next piece is kind of the core actions for 4 and 6, which are practical assistance and stabilization. These two, I think, do a lot in fostering trust and trustworthiness. The goal of practical assistance is to provide help that addresses immediate needs and concerns, helping individuals to identify, resources either in that immediate space of response that could help them. For instance, if they have an immediate medical need right now, it's getting them connected to the medical team, right? Physicians are healthcare providers that can address the issues that they're experiencing in the moment. And then providing the sources that can increase a sense of empowerment, hope, and restore dignity, allowing them to identify their own needs and not prescribing a need to them and prescribing the help that they might need. And then stabilization, creating that calm and helping them to calm and then orient emotionally can be really helpful in cultivating that sense of trust, safety, and comfort. When we're coming out of a disaster situation or event, it is very understandable to feel disoriented and emotionally overwhelmed. So the extent to which we're able to stabilize the individual, the more that we're able to kind of cultivate this sense of reliability and consistency for them.
So some ways that we can, I'm realizing we're almost at an hour and we're only about halfway through our principles of trauma-informed care, so I'll speed up just a bit, though we're going to be clear and consistent. But some ways that we can think about utilizing peer support and mutual self-help in the types of settings that we might be thinking about helping folks. One is allow for or plan for, if you can, a feeling of community or belonging. That can be so important in trauma response and disaster response, is that people are looking for a feeling of community and belonging. They want to feel connected to people in the aftermath of a trauma. And so if we can allow for that, set up space for that, just kind of fill the time with some of that, a feeling of a place for people to talk about what they've been through, to support each other. That's really a need that people are having that they might not be able to express even. Giving those who want to help something to do. It's a part of psychological first aid, I know, that Vaughn might talk about, but that there are those who want to help and that may be a part of the trauma response, but that can also be very helpful for them, is to have a place to channel that energy and something to do that's practical and helpful. So be aware of that, maybe have a plan for that. If there's a use for volunteers and a way to let those people be of help, that's a really useful thing. Showing those that are in traumatic situations that they're not alone. That's really the goal of using peer support, is that there's a feeling of isolation and aloneness after a traumatic experience. And so we want there to be opportunities for people to see that they're not alone, that they're not the only one who's experienced something like that. And that even though their response might be individual and their needs might be individual, that there are others who can understand and who can help. If it's possible to allow for group support, make that happen, or allow that to happen naturally, or facilitate sharing support. So if that emerges naturally in the environment that you're working in, that's great. And if you can help facilitate that, a feeling of people who have been through something together or at the same time sharing support of each other can be really great. Facilitation of that may be helpful because sharing of support can often devolve into re-traumatization. People can sort of go back into their trauma as they're sharing support. So that's where it may be helpful to have a professional or a helper facilitate that support, so that we're we're making sure people aren't re-traumatizing or re-triggering each other, in that they are truly just sharing support. And what we want to do is give people a sense that recovery from trauma or recovery from a traumatic experience is possible.
Yeah, I think we don't want to prescribe, right, what the individual's course of recovery is going to look like and how their responses might be. So looking at connecting to social supports and linkage to collaborative services as the core actions. Because everyone's reaction is going to be different, there may be individuals who have the capacity to serve or to help in that moment, in the immediate aftermath, and allowing them the chance to, take on tasks or provide support in the ways that they're able to can foster that hope of empowerment and self-efficacy, that they're doing something of service in that moment. That definitely fosters a sense of recovery, and that recovery is possible. Linking to available services or collaborative services, I think Jesse's point around having a facilitated conversation that can certainly happen in that immediate space, but an ongoing as well.
Yeah, great. And the next principle of trauma-informed care is showing collaboration and mutuality. And the ways that we do this are in asking people what they need rather than going into it thinking that we know what they need, or having a plan without having any sort of input about what's needed. That shows that we're working together, not we're working on it for them. Taking cues from those that we're helping or that the survivors that we're working with. So looking to them for what to do next or how to help. Giving messages of working together and positioning ourselves as having power with rather than power over those that you're assisting. There's sort of that old model of authority and professionalism that says, I'm the authority here and you're sort of lucky that I'm here for you. And that's not what we want to give people, especially after a traumatic experience. We want to say, we're here with you and we're going to work on this together, and we're going to be sort of in this and sharing our power here. That's the most helpful thing that we can do. And demonstrate, I think, as a team that we, the helpers, are working together is also a way that we show that we have a collaborative model, that we're not sort of one person's in charge here, and that nobody else gets to speak up, that there's a feeling of mutuality even among the team of helpers that's there.
Mm-hmm. And leading with, the individual is going to know themselves best. I think taking cue from that is going to really go far in showing that collaboration, that mutuality, and then building that trust.
Ways that we focus on empowerment, voice, and choice, which that's my favorite sort of term from trauma-informed care, is voice and choice. That really the way that we want to be talking with people is about that. How are we giving them voice, giving them choice, and empowering them? So as much as possible, we want to give survivors a sense of their personal power, and that's not lost because they've been through something traumatic, but that they still have that, and that we are going to help them use that and tap into that. We want to allow for people to give us feedback and share their needs, share their opinions about what's being done. But we don't ever want to be providing a service and never asking how that's received or if that is what is needed, because then there's no voice of the person in that. So as much as we can, we want to lay out some options and allow for choice in what happens next, rather than saying, here's what you need to do. We want to say, here are some things that we can do. What feels best to you, or what feels like your next right step, and to try to make that happen for people. And wherever possible, we want to use empowering language. That's you have the choice to, you're welcome to, wherever we can sort of give power rather than taking it away. And that taps into the difference between things we might say that are empowering versus disempowering. Take that, Vaughn.
Yeah. So looking at kind of cultural and historical gender intersection identities, I think it's really important to know and recognize some of the historical pieces for communities that you're going into and assisting. The impact of different responders and their roles in that community can really impact the way that they might receive that responder or that team. Being aware of that, and then allowing team members who might have a more neutral stance with the community lead the response might be a really nice way to respect the historical impact, and, create that sense of safety and comfort.
Some of the ways, oh, sorry.
Sorry, go ahead.
Go ahead. Some of the ways that we show and demonstrate that we're considering cultural, historical, gender, intersectional identities of people who we're working with are making sure we're giving space for the perspective of those that we're helping, recognizing and allowing for different views on trauma, different views on safety, different views on privacy, different views on communication, recognizing and adjusting for needs that might be difficult for someone to share or acknowledge due to cultural or identity norms. So if it's not going to be easy for somebody to ask for help, let's anticipate that and make help available, whether or not they have to say that they need it. Being able to sort of anticipate and be sensitive to that they may not be able to say exactly what it is that they need. And whenever possible, if we can partner with a community agency to better understand the local context and the cultural nuances, whenever possible, that's going to speak more to the people that we're helping.
Yeah, and in partnering, I think it's also seeking guidance on what the particular needs are that community might have, right? Because whether that's with spiritual leaders, whether that's with elders, or whether that's with other professionals who serve in that community.
So what trauma-informed interventions are, so there's kind of trauma-informed care more broadly, that's what we're talking about you can provide that in any setting. In a clinical setting, you're going to see trauma-informed interventions being offered. And what that means is really that they're involving patients in the treatment process, that we're screening for trauma and assessing for trauma upfront. We're, again, sort of assuming that people are coming in with traumatic histories, because most are. And so we want to gather that information so that it can help us to know what is going to be best as options for that person. We want staff in trauma-informed settings to be trained in both assessment of trauma and understanding of trauma, but also trauma-specific treatment approaches, of which I'll name a few in the next slide. And we want to be able to engage in referral sources and partnering with other organizations. So one part of trauma-informed care is not ending with a person abruptly and saying, well, that's it, you're done with me, I'm out of your care now. But being able to hand off care to the next place or to make a connection with another person that can follow up, or a referral that meets another need of that person, so that we're not leaving them to connect those dots and go to the next place that they need help, but that we can facilitate that as much as possible.
And having that conversation ahead of time and planning that out with your team, right? Maybe that's having a conversation with the response lead or whoever that might be, to be able to plan out what would a warm handoff look like, what would be available support ongoing look like, and kind of the duration of different needs that come up for that community.
These are some examples of trauma-informed interventions. There are more than this, but some that are offered in clinics that I've worked in and that have been established as trauma-informed interventions: prolonged exposure therapy that we may be aware of, EMDR, eye movement-based therapies. Seeking Safety is a skills group for people who have been through a traumatic experience that is often offered in a group settings, so where people can learn together some ways of dealing with some of the symptoms or the effects of trauma that they've been through. Some more child-focused, the last three are child-focused interventions: child-parent psychotherapy. So when it's the child that has been through a traumatic experience, we need to involve caregivers or guardians of some kind. And so we want to be doing some treatment that forms attachments and works with connections and social supports in the child's life. And similarly, attachment regulation and competency treatment is child-focused, but parent involved or guardian involved treatment. And trauma-focused cognitive behavioral therapy, TFCBT. These are all interventions that you can learn more about if you're interested, or if you want to do more clinical work with those who have been through traumatic experiences.
So when we're looking to share kind of trauma-informed mental health resources, we want to make sure that we're coordinating that follow-up, doing that warm handoff, but then also providing handout resources, or handouts of resources. Because, discussing in that moment, people are going to be able to take in information in different ways. So having that handout available so that they can reference back to, or at the very least, to know who to contact for additional assistance or additional kind of help navigating the different resources and follow-up care is going to be really helpful in cultivating that sense of next steps, recovery, and hope.
Yeah, and the other side of trauma-informed care is being aware of the needs of the helpers or of those of us who are doing the work, and knowing that it's possible for us to experience secondary traumatic stress, which is distress and emotional disruption resulting from continued or cumulative contact with individuals who've experienced trauma. So work that involves witnessing a great deal of suffering, either by observing or listening to narratives of trauma, can result in lasting emotional distress for us, for the health workers who are involved in this work. And so we need to be aware of that, aware of trauma as it impacts people around us, but also how it impacts us. And even experiencing that secondhand or through the stories of others or through what others have been through creates some of that traumatic stress in ourselves that we need to be aware of. The ProQual, the Professional Quality of Life measure and website, is a really great free resource for those of us in the helping professions who may work with those who have been through trauma. The model is really that we come into this work because we have compassion, we have a drive to help others. Many of our answers earlier that's what brought us to this work, was that we wanted to be of use, we wanted to be connected with people and of help. And that at its best provides a lot of compassion satisfaction. That's what we want to get from this work, is that feeling of rewarding work that we've done at the end of the day, that we've made an impact on people. But that counterpart of that is compassion fatigue, that we can spend time feeling drained by that compassion and that expense of energy toward others. And so when we spend more time in compassion fatigue than we do in the compassion satisfaction part of our work, it can lead to burnout, and it can lead to that secondary traumatic stress and exposure to trauma that we aren't prepared to work with, and that doesn't feel rewarding, and that wears us down over time.
And as part of the post-secondary traumatic experience, some of the ethical challenges that we might run into as practitioners in particular can exacerbate secondary traumatic experiences. So things like overpromising, under-delivering, dual relationships, and interpersonal boundary violations are things that might come up. Again, it's very natural for any one of us to want to kind of go all in and help as much as we can, because that's part of the helping reflex that we have. But making sure that we set kind of clear expectations, be as clear and concise about specific information as much as possible, acknowledging what we know and what we don't know, and what we can update or follow up on, right? And then acknowledging the available resources on hand, connecting individuals to different professionals or different team members so that they can begin to kind of gather in the information that they need to move toward their recovery. The dual relationships come up, especially with individuals who are responding in the communities that they serve. So making sure that you're consulting with colleagues, discussing with supervisors, kind of the plan for how you're going to manage dual relationships or the dual relationships that might come up for you, clarifying your role within the trauma response team, and then shared charting. So making sure that you're partnering with your colleagues or your response team members to chart concurrently, so that you're making sure that you have as accurate of information as possible, and that any team member following you can pick up on that information and know kind of exactly where you left off and where they can kind of pick up in coordinating the care that individual might need. And then interpersonal boundary violations, making sure that you are checking in with yourself about what, where your personal time is, what your social time is, and your intimate relationships. It's that old adage of you got to put the oxygen mask on yourself first before you can really effectively respond. If the disaster is impacting your community and you in particular personally, likely you're not going to be in a space where you can be on the response team and assist immediately. So making sure that you're checking in and seeing where you're at. And then assessing, making sure that you're deploying 2 by 2. I know for us as the Medical Reserve Corps and the behavioral response teams, or the different response teams that we have, we're consistently making sure that we're doubling up and responding in pairs.
Yeah, so again, this professional quality of life website offers a measure of professional quality of life, which gives you a measure of your compassion satisfaction, compassion fatigue, and potential secondary traumatic stress that you have experienced through the helping profession that you're in. And so it's a great measure to sort of say, where am I at in my compassion satisfaction and compassion fatigue? And it also gives tools for what to do in caring for yourself in the face of difficult work. This is a little kind of laminatable pocket-sized card of things to remember to do for ourselves when we're doing this hard work, so that we don't get burned out and we don't spend our time in the compassion fatigue that can happen. So, and it's basic things, but it's things we might not think about, especially if we're working in disaster response and we have a really difficult day, but we sort of feel like, well, that's the nature of the job and I had to do that and I just need to move on. But to really take some time to recognize the impact of that even if it went well, that you heard some difficult things, you experienced some people who had been through trauma, and that you need to offer some care for yourself to counteract that and to build resilience after that. So it also talks about how to focus on empathy rather than compassion fatigue. Empathy is an endless resource that we have, that we can remember why we do this work after a difficult day. It brings back the meaning of what we're doing when maybe we lose sight of that in the middle of a difficult situation, and how to also set boundaries for ourselves between work mode and off work mode, which can be difficult for a lot of us to sort of say, I leave that heaviness there and I have to leave it behind, and give myself time to restore before I go back to it.
Yeah, and making sure that you're acknowledging for yourself when you need that break or when you need to step away. I think it can be very natural to want to continue to, like Jessie said, just give and give, and not always check in with ourselves and what we need.
So guys, 15-minute warning, or maybe like 10-ish minutes. We only have one question, so I think we can keep going.
I think this is our second to last slide. I think we're almost there.
Okay.
So
Awesome.
just an invitation as we wrap up the information part of this is for you to reflect on what elements of trauma-informed care felt most applicable to the work that you've done or that you are doing. What resonated the most or felt the most energizing and exciting, or sort of applicable in ways that you can make change right away. And what will you do differently going forward based on this information? So as you think about what questions you may have for us based on this presentation, I hope you'll also think about that. What are you taking away that feels useful and feels like something you can do with this information?
So here are our references and just resources for you all as you look into exploring kind of trauma-informed care more and PFA a little bit more.
Oh, this is my turn. Okay. Yeah. So just for those of you who aren't familiar with our University of Minnesota Medical Reserve Corps, I just have a couple slides that talk about our unit. We are celebrating our 20th anniversary this year, so we're super excited. We were founded in 2004. We actually have a party today after this, so those of you who are local here and might be on campus, come over to the Kaufman Theater between 3 and 6 and say hi and have some good food and get some really good swag. I don't have any of it with me right now, but we got some cool sunglasses and some stickers. But just providing an opportunity to celebrate our members, our volunteers, our partners, and all of the great things that our Medical Reserve Corps team does here at the university. Our MRC members are part of our health sciences schools. There are 6 health sciences schools, as well as our partners at Boynton. So that's where Vaughn practices, and other medical, or our community university healthcare center is also part of our medical reserve corps, and a few undergrad courses. Future Physicians, which is a course for non or underrepresented and possibly first generation college students that are looking to get into medical and health fields. We always want to give opportunities for our students to see what we do and get some hands-on experience, take training like this. So I'm really passionate about making sure that we make our training and our resources that we have at the university available to as many people as we can, because that just makes us stronger as a unit when we go to respond to something either on campus or in our community, or perhaps in a neighboring state or another part of our country. So I am really, really, really proud of our Medical Reserve Corps. Next slide, please. So this is just a fun little slide. So HERO, for those of you who aren't familiar with our office, is the Health Emergency Response Office. Obviously, we like to make a play on that acronym, and we call ourselves superheroes, and we all have a superhero alter ego. Mine is Wonder Woman. This is kind of this is a photo of our director, Jill, who's on the left. Kathy Berlin, who was our MRC coordinator for 16 years, who I stepped in to take over for about a year and a half ago. And then on the right is Joan. She was kind of our original clinical response planner here in HERO. And then to her left in the Spider-Man shirt, that's Catherine. And she took Joan's role when Joan retired. So we're still all really close, and we like to have fun together and have little parties once in a while. So I just thought that this was a fun picture to show that we are a team. We are going to support you. We are going to make sure that any of our MRC volunteers that are ever deployed are feeling safe, feeling comfortable, have the knowledge and the information that they need to respond, not just in the moment, but afterwards as well. So it's really important for us as an office and as an MRC to make sure that we provide everything that Jesse and Vaughn talked about and more, as part of our support of our members. Next slide. All right, so let me just look here at our Q&A. So how do you manage where there is language or interpretation issues?
Great question. Yes, I think whenever you can have interpreters or cultural ambassadors present physically, that's a wonderful tool, and that's probably the best case scenario, is that you recognize that there will be a need for interpretation or language differences, and that you anticipate that and have some resources available. And there are so many other mediums now available, other media for language and interpretation. We at our community mental health center use the language line quite often for both phone calls to people, or for even live interpretation, that somebody can be on the phone translating for us. Or we also have some cultural ambassadors who are willing to come or do a phone call with people. So there are options, but I think the primary answer is to anticipate that that's a need and to plan for it rather than waiting for it to emerge as a need, so that you can be planful and have that available so people don't feel like they're a burden when they need that.
Right, absolutely. Thinking, I can't agree more, Jesse. It's just thinking ahead of time, knowing kind of the area that you're serving in, where the emergency response or the trauma response team might be deployed, helps to plan ahead and identify cultural ambassadors, language, dominant languages that are spoken in that community, and how we can either provide or develop handouts or resource information in that particular language ahead of time. I think would be really helpful.
Does anyone else have any other questions? Go ahead and put them in the Q&A.
I think if they raise their hand, you can unmute them, right? So if you
I
want to
think
raise your
so.
hand, we could try to
Yep.
figure that out too.
While we wait for any potential questions, I just wanted to thank you guys. Like, I learn so much every single time that I attend or help plan or facilitate one of these topics and these webinars. I think every slide that we had could be an entire hour training in itself. So there's so much more to this. So if any of you as participants are interested in, a deeper dive into a particular topic, I'm going to be sending out a training evaluation in the next couple of days. So please share any ideas or thoughts that you have on, more training. We're always looking for guidance from you all in what you are interested in and what you want to learn. So on behalf of all of the participants today, thank you, Bon. Thank you, Jesse, for sharing this. I really, really appreciate it. It was just a ton of good information. I think I don't see any other questions, just a few thank yous. Like I said, I would love to see you all that are local come to our party today. Otherwise, look for a survey from either me or the Medical Reserve Corps email probably by Friday. And would love, your feedback on this presentation.
Yeah,
Thank you so much.
thank
All
you.
right. Thanks, everyone.